class, we're talking about neurological disorders today. Excuse how I look, I'm just being really casual today. And the neurological system begins on page 472 in your med-surg book. So, when we're talking about the nervous system, first let's look at a quick overview. Organization of the nervous system. You have the central nervous system, which is the brain and spinal cord, and then any other nerves outside of that are the peripheral nervous system. So peripheral nervous system are nerves outside the brain and spinal cord, abbreviated PNS. You have 12 pairs of cranial nerves and you have 31 pairs of spinal nerves. You do have a chart in your book on page 475. And your cranial nerves are listed there. There's actually a mnemonic listed in your PowerPoint that you're going to be sent, and also there's a mnemonic in your book for remembering those. If that's a way you like to do it, that's fine, but try to be familiar with your cranial nerves, and in class we're going to go over something to help you remember those. All right, so your peripheral nervous system also includes afferent and efferent divisions of neurons, reflex arc, the cranial and spinal nerves, and sympathetic and parasympathetic nervous system. When we're talking about afferent and efferent neurons, just to make a differentiation, your afferent neurons are also known as your sensory neurons, and they transmit to the central nervous system, and your efferent neurons or your motor neurons, they are going to transmit away, receive impulses and transmit away to the body, to the muscles for on a descending track for movement in the muscle. So that's the difference in afferent and efferent. And when you think of your afferent neurons, think your sensory neurons and your vision. And when you think of your efferent neurons, think of motor neurons. And also your book has a picture on page 474. All of these diagrams in your book are fabulous. So I would like for you to look through each of these diagrams as you're studying each of your pictures. Paying attention to your different sections of the brain, your parietal lobe, frontal lobe, occipital lobe. Just kind of make sure you know where those are. And when you're looking at your dermatomes, those are distribution pathways. The nerves link the body to the brain and spinal cord through distribution pathways called dermatomes. That's on page 474. There's also a chart at the bottom of 475 about the functions of the divisions of the brain. So look over that. Your cerebrum is the center of intellect and consciousness. Cerebellum, center for coordination. Thalamus includes the spinal cord and cerebrum, relaying messages between those. Your hypothalamus has to do with the temperature of your body, water balance of the body, appetite, and your brainstem is divided into the medulla oblongata, midbrain, and the pons. And we'll talk about near the end of this chapter about ways to decide about good functioning when you're assessing your patient that you think might have a brain injury and a loss of consciousness. So we'll talk more about that later as well. But look at your different divisions of the brain and look at your functions and the comment sections of that chart. You'll have a couple of test questions about that. All right, cranial nerves and your functions. Look over that chart as well. And when you see the word pyramidal tracts, that has to do with skeletal movements, and extrapyramidal tracts deal with muscle and your posture and your balance. Sometimes in nursing, I remember early on, I would hear those terms and I would think, what are they talking about? So that is your pyramidal and extrapyramidal explanations there. And when you hear the term somatic nervous system, that is responding to changes in the outside world, and the somatic system is voluntary. And that is, well, I'm not sure. I'll come back to you with that. Okay. All right, so your central nervous system provides protection, nerve conduction of impulses, and your PowerPoint talks about brain cells cannot be replaced, but in the PNS, then your Schwann cells can regenerate. So read through that section, and that is at the bottom of page 476. Neurotransmitters. There's all types of neurotransmitters listed here: acetylcholine, norepinephrine, etc. I'm on the bottom of page 1 on the PowerPoint. Some of your neurotransmitters are excitatory and some are inhibitory. And you see a good breakdown of that, the autonomic effects on various organs of the body there. But your neurotransmitters are going to help the stimulus travel normally between the neurons when you're talking about nerve impulses being transmitted. Also wanted you to look at cerebrospinal fluid. It circulates within the subarachnoid space, cushions, protects, and is formed continuously. Cerebrospinal fluid, or CSF, normal is 70 to 125 centimeters in water pressure. That is on page 476. Okay, age-related changes in regards to the neurovascular system. Older persons may need more time to process questions, solve problems, or learn new information. Your chapter will talk more about this near the end of the chapter. Using the brain and keeping it active promote continued intellectual function in healthy older adults. Okay. And just a second ago, when we were talking about brain cells not replenishing themselves after they're destroyed, sometimes cells in your brain, particularly in a younger person, can take over for cells that have degenerated. And then, like we said, the peripheral nervous system, some cells can regenerate. And you've probably already learned when you were learning in CPR, when someone is not responding, we keep doing that good CPR to pump blood to the brain, because after 4 to 6 minutes, you can have brain cell death. All right, neurologic disorders, causative factors, prevention, and health promotion. So this will be some of your jobs as a nurse to help prevent neurological disorders. So a lot of different ways to do that: educating about safety and responsibility, educating about prevention, as in not using drugs and substances that can be harmful to a body, health promotion, controlling hypertension, controlling high cholesterol, because those two things lead to stroke or cerebrovascular accidents, so we want to prevent that. We want to keep our autonomic nervous system healthy to decrease the chance of strokes. Parkinson's is also associated with pesticides, and so your book talks about people who use those, farmers or people who deal with lawn care and things like that. They need to be sure and wash their hands very well, wash the clothing that they use after working with pesticides. Teaching children, young adults, wearing helmets, safety equipment, being careful about diving or swimming, wearing seat belts in the car, personal protective equipment, as we just discussed, and refraining from using recreational drugs. You've got some classifications of common neurologic disorders in your book. Genetic or developmental, an example of that would be cerebral palsy. Trauma, of course, is head injury. Cerebrovascular neurological disorder could be due to a cerebrovascular accident or stroke. Another common neurological disorder is a tumor. There's different kinds of tumors, brain tumors. Infection can cause neurological problems such as encephalitis or Guillain-Barré. Neuromuscular disorder, neurologic disorder, an example could be ALS or Lou Gehrig's disease. A degenerative disorder could be Parkinson's, and a cranial nerve disorder, an example of that could be Bell's palsy. All right, evaluating the neurological system. We'll talk in just a few minutes about doing a neuro check on your patients. You'll use that quite often during nursing, but when you have a patient who's admitted under your care and you think they might have a neurological problem or they have a neurological complaint, then you need to go through a full assessment of neurologic status. And your book talks about that can be done over a matter of time. When you watch the person even come into the room where you're helping to take care of them, of course you're checking their vital signs and looking over their chart. You can see how they walk into the room. Are they having to have a great deal of help from a family member? Did they walk in on their own? Are they able to talk to you and tell you about what's going on with them? Are they relying on other people to do that? So that can be a good way of getting some knowledge about their neurological status. Are they balanced? Do they have good coordination? Your book talks about the Romberg test. I don't know if you remember that, but having your patient stand still in front of you, close their eyes, and just see if they can remain in upright position, or are they leaning over as they're standing still. I wish we were in class and we could practice all of these together because it's quite fun to do neurological checks on each other. Neuromuscular function test, grip. Just say, can you squeeze my hand? Check both hands. Have them hold their hand up and put some pressure. Can you push against my hand? Things like that. Check their patellar reflex. That could be just a quick, easy reflex that you check, which is a knee-jerk automatic response. And that's an example of a reflex arc that your book talks about. You can watch your patient walk to assess their gait, assess their walking, and see how they're doing. All right, and a gross assessment of major cranial nerves. This is on page 480. There's different cranial nerves that can be checked, and of course, we're going to talk about PERLA when you're checking the pupils, equal, reactive to light, and accommodating, so you can go through that. Check their chewing motions. Are they able to chew? Can they smile? Can they puff their cheeks? Do a whisper test. So stand beside them. We're going to talk more, like just about right here. We're going to talk more about a whisper test when we talk about the hearing function, and whisper to them and see if they can understand what you're saying. Repeat it back to you. Glossopharyngeal and vagus, and that's really just assessing their swallowing. Can they open their mouth and say, ah? That's assessing that. Spinal accessory, can they shrug their shoulders? Can they turn their head? Hypoglossal, what is their tongue strength? If you ask them to put their tongue against the side of their mouth on either side, can they do that? Put your hand here and see if they can press their tongue against your hand. Okay, reflexes. We talked about the patellar reflex. Your book also goes through the Babinski reflex. Remember when we were talking about newborns, we talked about a positive Babinski? Well, we don't want adults to have this positive Babinski, okay? So read through that section. Also read through the section about the oculocephalic or doll's eye response. And it just goes through putting your hands on the side of someone's head and moving their head side to side. You see how my eyes are moving the opposite of the way my head is going, so that's good. Your eyes move with the movement of the head for a positive doll sign, and that shows an intact brainstem. Miss Pam has an intact brainstem today. If the eyes remain stationary then that would be a negative doll's eye. So that would be that my eyes are just moving as you're turning your head. So that would be bad. There's also caloric testing that can be done, osteovestibular reflex, where water can be placed in the ear, and that should cause the eyes to have some involuntary movements called nystagmus, which is good. That's what you want to happen. So read through that section about caloric testing. An absence of eye movement would be a bad sign, negative sign. And your book also talks about assessment. So we want to go further now and do some more assessment on our patient. So when you have this patient checked in under your care, you have to take in mind their existing condition, okay? If you have a patient who's coming in under your care for a bowel obstruction, they may also be a previous CVA patient, or they could be a Lou Gehrig's disease patient, and they're coming in for a bowel obstruction. So take into mind they may have some sort of existing neurologic disorder. Glasgow Coma Scale, that is on page 485. So always keeping that in mind with your patients. We're going to talk more about that in just a few minutes. Physical assessment, vital signs, mental function, level of consciousness, all of this is taken into consideration with the neurocheck or neurological exam. Asking your patient if you think they seem confused. What is today's date? When is your birthday? Do you know where you are? Who do you have with you today? Have them do a simple math equation. Can you tell me what $1 minus 50 cents equals? Something like that. So simple math, have them follow your finger, see if they can follow your finger to do a simple neurocheck as well. Vital signs can tell you, of course, a lot about your patient and how they're doing, but also it could show a possible brainstem injury. That can affect their vital signs. It could affect their temperature, since your brainstem has to do with temperature regulation. And your book talks about a widening pulse pressure. So read through that section about changes in blood pressure and widening pressure, and how that can cause or be a sign of increased intracranial pressure. There's lots of signs of increased intracranial pressure, but that's one of the first one that's brought up in that chapter. Lots of pages about nursing management, nursing diagnosis, planning, implementation, evaluation. Some key points I wanted to bring up about that is looking through your nursing diagnoses. Read through all those on page 489. So get you a coffee and just read through those. Read through all of those goals and expected outcomes, nursing interventions, because there's a lot of them to read through there. You always want to think about your patient and can they be injured. So that might want to be one of your top priorities, is potential for injury. Teaching the patient about their illness, teaching the family members about their illness. When you have a neurological problem or deficit come into the family, it can be a big blow for family members. There can be some grieving. There can be some psychosocial issues that come to be in the family. So all those need to be addressed. A good answer for someone's having trouble breathing, is get the head of the bed up. So elevating the head of the bed. You may need to involve physical therapy, occupational therapy into the patient's care. Constantly assessing their neurological status. Are there any changes? Watch their activities of daily living. What are they able to perform for themselves? And what they can do for themselves, let them do. But watch them, watch their walking, and also referred to as gait, watching their gait. Can they feed themselves? Can they swallow? Very important. Can they follow commands if you ask them to do something? And I wanted you to pay attention to your Glasgow Coma Scale. which is on page 486 at the top. So look through that Glasgow Coma Scale. Make sure you understand a 15 is fully alert and a 3 is comatose. That is still used widely, but also your book mentions the 4 coma scale, which is becoming more widely used. So read through that section as well, where 0 is the value for coma and 4 is the value for normal or fully alert. Your book also talks about if you think someone's not responding to you well, if you think their neurological status has changed, there's some tests that you can go through with your patient. The last one being the sternal rub, which it talks about will cause a lot of pain and it can cause bruising for your patient. Your book also goes through some common problems of patients who have neurological problems, and generally if they are in pain, we are generally not going to use narcotics for this patient. Confusion for them can be short-term. They can have periods where they feel very confused and they're very agitated and restless, and then they can have periods where they're calmer. But when they are agitated and restless and seem to be confused, try to remain calm yourself and just explain to them calmly what's going on, where they are, who you are, that you're taking care of them, what's happened to them, and try to be orderly about what you're doing and have a routine for your patient. Your book talks about different types of aphasia on page 496. So make sure and read through that section. I'm trying to get you a little guest speaker about that. Sexual dysfunction, of course, can occur. Ineffective family coping. So this family may need counseling and support that's dealing with this new neurological illness. Incontinence can be a great problem, obviously, that's dealt with someone who has a neurological problem. They do need to, unless it's contraindicated for some other reason, if they have congestive heart failure or something, they need to be taking in 2,000 to 3,000 cc's of fluid prior to 6 p.m. So try to get them to taking in their fluids all during the morning, and then so that you can kind of plan on when to help them out with going to the bathroom. They still may be able to void by placing some pressure on the bladder, or they could be a person who is able to do self-cath. They may be taught to do self-catheterization at home. Some patients with neurological disorders don't have good bowel function, so they need some bowel stimulation, where actually the caretaker can just put on a glove and put some finger into the anus and do some stimulation to help with bowel activity. If they're able to sit up on the potty chair, of course, that can help with just placing times to do that, maybe within 30 minutes after eating or something like that. Also wanted to go over a few other things. All right, some terms that are on page 492, hemiplegia, hemiparesis, and tetraplegia. Be sure and look through those terms. Tetraplegia is another word for quadriplegic or quadriplegia. Those who have neurological damage in their extremities, sometimes it can be very good for them to elevate the extremities to keep from having swelling in the extremity. They can have muscle spasms, something to keep in mind. Also look at the term dysphagia, difficulty swallowing, and anytime you're going to give someone medication in the future and you think upon check-in you're assessing them that, hey, maybe they may have some trouble swallowing, you want to give them a sip of water and see how they swallow first, of course, before you give them a pill with a glass of water. So those terms are on page 492. Also wanted you to look at decorticate and decerebrate posturing. for your patient who is in coma, possibly. And this is a level of response that their body might be going through. So one way that I remember decorticate posturing, if you look at the picture on the top of page 487, you see that their arms are up, turned like so in decorticate posturing, and this can show up with damage to the cortex, or decerebrate posturing, their arms are extended down to the side, and this can be with brainstem damage, which is, neither one of those are good things obviously, but that would be worse, because when you have damage to your brainstem, then you have damage to the center that controls respirations, temperature, heart rate, so they are going to, have a lot more damage and possibly death. So look at the difference between those. Also wanted you to review PERLA, Pupils Equal Round, Reactive to Light and Accommodation, PERRLA. And when you check your patient in, look at the baseline for them, okay? Look at their pupils with your pen light, and when you're doing your checks, see what their pupils look like normally so that you can look at changes. So then if you come in the next day and their pupils look different, and that's something you need to alert their care provider to. If both pupils are dilated and fixed in bright light, that is a sign of brain damage. If one pupil is fixed in bright light, that can be a sign of increased intracranial pressure. And both of those in your book. Okay, so let's talk about neurochecks for a second. Neurochecks are something that you're generally going to do on all your patients. You guys know I worked in OB for years, but obviously I still did neurological checks on my patient when I went into the room in the morning to say hello. If I didn't have time to do their full assessment, I don't know if you guys remember me talking about, I at least went in and make sure that they were doing well, make sure that they know I'm Pam and I'm going to be your nurse, and here's my phone number and here's how you can call me. They might have been breastfeeding their baby at the moment or something like that, or they may have been asleep, and you and I both know that if you've just had a baby, you want to get plenty of sleep. So I didn't wake them up at 6:45 in the morning to do their full assessment, because I can do that in an hour when they're awake. But anyway, I always did a neurological check. You'll be doing neurological checks on all of your patients, whether they're an OB patient, neuro patient, cardiac patient, someone coming into your ER, whatever. Your physician may order neuro checks every 15 minutes or every 2 hours or something like that. But anyway, underneath a neuro check, vital signs fall underneath that. Also, level of consciousness. So obviously, if they're alert, able to answer your questions, then great with their level of consciousness. So you may just have a check-off box on your patient assessment that you're doing that they're awake and alert. Pupil reactions. So we're looking at PERLA. Like I said before, just seeing if their pupils respond as they're supposed to. Do they respond to light? Are they accommodating?